Good evening, all. A happy Diwali to all participants from the Simsa family. Myself, Mishal Mohammed, third year medical student from GMC Code. With so many horrific diseases plaguing the world, the role of radiology is paramount in the healthcare sector as it helps physicians by providing many options, tools, and techniques for accurate detection and staging and treatment. With the ability of early detection, radiology saves lives too. Beyond just academic excellence or cracking PG examinations, radiology has got tremendous importance in physicians, budding up physicians like us. It is a basic quality for any doctor to know and learn how to read an X-ray or a CT or an MRI. With this current COVID pandemic situation, it has become a cumbersome for all of us to get into our clinical rotations. So, we present to you Introduction of Radiology as we mark November 8 as the International Day of Radiology. It's also the 125th anniversary of discovery of X-ray radiation by Wilhelm Röntgen, a discovery that has revolutionized the field of medicine. Let me welcome to you Dr. Shanida MP, Assistant Professor, who has published as many papers and has brilliant academic excellence from the Department of Radiology of Government Medical College Code to give us a sneak peek into the basics of radiology and chest x-rays. Thank you. Shanita ma'am, you may start your session.
Okay. Thank you, Michelle, for those kind words. Uh, Welcome, students, to this academic session. I'll be talking about basics of chest radiograph. Before going to the topic proper, I'll just take you briefly through the history. All this happened because of German physicist William Conrad Röntgen, who accidentally discovered some rays called X-rays. He was actually experimenting with the conduction of electricity through tube under low pressure, and he found that there were few rays which traveled from the positive electrodes and caused glow in the fluorescent screen and fogged the photographic plates. He named those rays as X-rays because they were not having any charge, they were not deflected by any magnetic field, and they penetrated through light opaque objects. And from that point, the branch of diagnostic imaging started. These are basically electromagnetic waves with short wavelength. And these rays could pass through most objects and casted shadows, including human tissues, but not human bones and metals. Within a year of the discovery, many scientists replicate these experiments Röntgen performed and began using it in a clinical setting. This is a photograph of Röntgen, and this was the first radiograph he took of his wife, the hand of his wife, Anna Bertha. And he won the first Nobel Prize in the branch of physics in 1901. Having said that, as we have said that these are penetrating radiographs, when you take a radiograph of the chest, how is it going to appear in the film? So our body, the chest, has structures which are of different densities, meaning different atomic number basically. The bones with higher density, the soft tissues of intermediate, finally the gas inside the lung with lowest density. So when the X-rays are passing through these structures, these will be stopped differentially by these structures and finally will appear different in the radiogram. So while talking about the radiograph, we have to answer certain questions like, why do we need a radiograph and how do we get one? What are the basic technicalities involved? What is a normal appearance? What is a basic checklist? And finally, the important abnormalities. by the end of in this lecture, I would want you to have an understanding of a normal chest radiograph, assess the technical quality of a radiograph, utilize a systematic and reliable approach in chest X-ray evaluation, and able to identify common chest X-ray findings. As I said, the bones will stop more, so will be appearing as white. The least dense, the air, will be appearing black, and all the densities in between will have the different shades of gray. So that's what is called a black and white theory, meaning the images seen on the chest radiograph result from the differences in densities of the materials inside the body. The hierarchy of the densities from the darkest to the most dense, the lightest include the gas being dark, the fat in between, water dense, bone the most dense, and if there is a foreign body, a metallic thing, it will be the densest of all the structures seen. So it is depending upon the differential absorption. Say, the more the X-rays are stopped by the tissue, they will be appearing more whiter on the radiograph. So how do we get a chest radiograph? The question I want you to answer is, what is a view that is taken? When you have a radiograph, when you say, as a clinician, you send for a radiograph of a patient, or as a clinician who is going to interpret a radiograph, you should know what is a view that is taken by the radiographer or from the department. So by default, the radiographs are usually PA. Less commonly, there are other radiographic views, including AP, lateral view, lateral decubitus, lordotic view, apical view, and oblique views. What does it? How do we know? I mean, what does it mean by this PA view? This PA just refers to the direction in which the X-rays are going to travel. Meaning, this is an X-ray tube on the one end, and you can see the X-rays coming through from the X-ray tube, and is going to traverse through the patient, and finally is detected in the receptor. So the direction in this patient, the radiograph is going to hit the posterior aspect of the patient and is going to exit through the anterior aspect. And this is simply the PA view. So unless specified, a radiograph is PA. These are the other views where you can see patient supine and sitting, where the X-rays will be hitting the anterior aspect of the chest first and is registered or recorded in the cassette or in the detector kept on the posterior aspect, and that is the AP view. And in lateral view, the patient stands usually left side touching the cassette, and the X-rays pass through the lateral aspect and exit through the other lateral aspect of the chest. So these are the different views obtained in radiograph, including PA, AP, and lateral view. Is it important to know these views? Yes, because PA view, as I said, is taken in a in a patient who can stand erect, who can obey commands, and is usually for help, say the patient in an OP setup, or the patient could obey commands like to take deep inspiration and all. If the patient is bedridden, if the patient comes into the casualty after a trauma, if the patient is frail and he or she cannot stand and cannot obey the instructions, then we cannot take a PA view. Then we opt for an AP view. But as the person who is interpreting this radiograph, we should know the essential difference between these views in the radiograph. What is finally going to happen? How does it differ when you take a PA view and an AP view? So on the right side of my screen, you have a PA view, and on the left side, you have an AP view. When I say right side and left side, it's always a radiologist's right and left side. So you may say the left side radiograph and the right side radiograph. Okay, I will not confuse. So the right side radiograph is taken in a PA view, and the left side radiograph in a PA view, and the right side in an AP view. This is a PA view. This is a AP view. And how do I know that this is PA and AP without having to see how the radiograph was taken? I know because when I see the radiograph, I can see that most of the lung is aerated, meaning I can see the aerated lung up to here. I can see the posterior ribs more obliquely placed, the clavicles in an oblique fashion, the scapulae not overlapping the lung fields, and there is an air fluid level in the stomach bubble. On my right side, this radiograph, you can see only part of the lung is opacified, is aerated, and you could see an apparent cardiomegaly. There is horizontal orientation of the posterior ribs. The clavicles are projected above the lung, and I can see the scapulae overlapping the lung fields. So what does that mean? The patient was bedridden and he was not able to be upright, so that the proper positioning was not done, and finally a AP supine view was done. So when in supine, the hemidiaphragms go up and only part of the lung aerated is seen, and you get cardiomegaly, apparent cardiomegaly, scapulae overlap the lung fields. So the by looking at the radiographs, you should be able to see, say, whether it was taken PA or an AP view. To recapitulate, there in a PA view, you can see the air fluid level in the stomach. The posterior ribs are oblique, the clavicles are above and is oblique, the scapulae are out of the lung fields in PA, and in AP view, the ribs are more horizontal, the scapulae overlap the lung fields, the clavicle are also more horizontal. Now coming to one more view, this is very important clinically, called as lateral decubitus. Here the patient is lying down on his side and the radiograph passes like an AP view. This is a clinical case where you can see there is an opacity which is obliterating the CP angle. I'll come to the anatomy later. I'll just go through this view at this point, and you can see it is obliterating the CP angle, and the diagnosis was a pleural effusion. I want to know whether it is a loculated effusion or a free effusion. So the modification of a lateral decubitus was made in this patient, and this radiograph is positioned as though the patient is lying down, and you can see the fluid going up and lining the hemithorax in the dependent portion. So this is a free fluid. I have I have made it upright, and you can see the fluid going up when the patient was lying down on the left lateral decubitus position. Finally, before going to the pathologies, the radiograph should be taken in ideal situation so that we may not overcall or undercall any pathology. Okay, so how do you assess the technical quality in a radiograph in the final image? There are actually three main factors. One is additionally included. Usually it is rotation, penetration, and inspiration. Inclusion is a newer one. So inclusion. When you have a radiograph in front of you, you see that these structures are seen within the radiograph. That means you are not going to miss any pathology due to exclusion of that structure. Okay, that is properly positioning. You see that the clavicles are seen. You see that the lateral end of the chest wall is seen. You see that the CP angles are seen. Okay, costophrenic angles are seen clearly. Now coming to rotation, the importance is that any aberration from the normal can have gross abnormalities in a normal radiograph. What we see as normal will be abnormal if the patient have a rotated radiograph. How do we know the radiograph is not rotated? Take the radiograph, trace the midline. You can see the spinous process in the midline, and draw a line to the medial end of the clavicle on either side. This should be equidistant. Any abnormality, any difference in measurement causes distortion of the normal anatomy, and you may overcall what is normal. So here, this was a patient who was in the ICU. You can see the cardiac pacemaker, and we may interpret as mediastinal shift, some pathology on the left side, etc. But you should the first thing you should know that you should notice that it is grossly rotated to the right side. So the complete mediastinal shift is not actually pathological, only positional. So make sure that you are interpreting a normally taken radiograph. Now coming to penetration. What is penetration? you please don't bother about what are the factors, what is the KVP, what is the MA that was used while taking the radiograph. You assess the final quality. How do you assess the penetration? Is the radiograph too white or too dark? And what is the right penetration? It is said that while looking at a radiograph, through the heart, the spine should be just visible. That's the word Ben Felsen uses to describe a radiograph. That is, the posterior spine should be just visible through the cardiac shadow. So if it is not seen, it is underpenetrated. And if you are able to see whole of the spine in entirety and the lung is becoming more loosened, it is overpenetrated. So the lower thoracic vertebra should be just visible through the heart. That is the appropriate penetration. These are the overexposed and underexposed radiographs. Is the radiograph too white? Am I able to see the spine? No, this is underexposed. And here the lung is appearing too dark. I am not able to see the ribs even. And you can see the whole of the spine here. This is overexposed. So as I said, we are going to diagnose mispathologies, overdiagnosed pathologies with these kind of aberrations from normal exposure. So in an underexposed chest radiograph, the cardiac shadow is more opaque with no or little visibility of the thoracic vertebrae. The lungs appear much denser, whiter, and can have appearance of infiltrates in the basal zone. Coming to the most important thing, that is inspiration. We want to see the whole of the lung in the radiograph. For that, we ask the patient to take a deep breath and we take a radiograph. So the whole of the lung should be seen. For that, it should be in the inspiratory phase. How do we know the radiograph is taken in the inspiratory phase? In the image, you should be able to see 6 anterior ribs, 8 to 10 posterior ribs above the hemidiaphragm. And how do I know what is posterior, what is anterior? That you start tracing the ribs from the posterior elements. And what is coming proximally, the first is the posterior aspect and then the anterior aspect. Again, the posterior aspect, then the anterior aspect. The posterior aspect, the anterior aspect. So likewise, you count the ribs, and the posterior 8 to 10 ribs should be above the hemidiaphragm and 6 anterior aspect of the ribs should be above the hemidiaphragm. That's how I know it is properly taken radiograph. Otherwise, if it is an expiratory film, I'm going to overcall various basal opacities. I'm going to overcall a cardiomegaly. I will miss basal opacities in the basal lung zones. Okay, so this is how you count the ribs, and you can see the clavicle marked. And what is how does it differ when you see an expiratory and inspiratory image? As I said, the lung is more volume. The volume is maximum in an inspiratory radiograph. And see here, this is an expiratory radiograph, and you can see there is cardiomegaly. Actually, it's an apparent cardiomegaly. That's what we call. And you can see there are opacities which are actually the basal normal lung parenchyvascular markings in the basal zone. They are not actually infiltrates. So we start to overcall it as basal infiltrates. So make sure that if you see a radiograph like this, make sure that you repeat a radiograph. Ask the radiographer to get a repeat radiographs with the full inspiratory effort. And now you start interpreting the radiograph. So to summarize the quality assessment, I'm going to see whether the radiograph include everything that is needed: the clavicle, the lateral end of the chest, the CP angles, the hemidiaphragm. And I'm going to see that the radiograph is not rotated by assessing the distance between the spinous pros and the medial end of the clavicle. I'm going to assess the inspiratory effort of the patient by seeing counting the ribs. And finally, the penetration by just seeing that the posterior spine is barely visible through the heart. So I have assessed the quality, and it is fine enough to have all these things fit in the quality to proceed for an interpretation. Now coming to what is normal. It's a difficult area. At the end of this session, you will be seeing the radiograph of the patient like this, but you will have all these structures in your mind when you see the radiograph. Okay, let's get started. There are various methodology by which you review the anatomy. There could be an ABCDE method, A airway, B bones, C cardiac, D E rest of the structures, etc. And what I will be talking here is about the way I interpret the radiograph. So you keep a mnemonic, you try remembering it, and the final thing should be you should not miss anything. That is the final verdict. So basically, I want you to look at the airway first. Airway. This is a mnemonic for the basic resuscitation also. You know that. So you have a radiograph and you start to see. You start from the airway. Okay, what is this? This is trachea, that is central. It is dark because it has air inside it. So I will trace the trachea, tracheal air column, and till the division where it is called the carina. It divides into right and left main bronchus. So I'm going to see that the trachea is center. It can be minimally deviated to the right side and never to the left side. The lumen should be seen clear. And you can see the carina where the carinal angle, the angle of division of right and left main bronchus is around 60 to 70 degree. And any condition that will cause widening should be looked for, like in mediastinal lymphadenopathy, left atrial enlargement, mitral stenosis, etc. And again, I don't stop at carina. I trace the right main bronchus and the left main bronchus, and I know that the right is more aligned with the trachea. It is short and steep, and that's why most of the foreign body in children get aspirated and lodged in the right main bronchus. After that, once I have traced the trachea, one thing I want you to remember at this point is, please see the trachea superiorly above the chest. Any thyroid lesion can be missed with significant airway obstruction if you don't look at the neck portion of this radiograph. Okay, so remember to view the superior aspect of the trachea and the luminal narrowing by any neck lesion, mostly the thyroid lesion. Now I have these two structures on either side. After the trachea, I'm directly going into these structures. What are they? They are 𝗓𝗏. 𝗓𝗏 are the windows on either side from where the mediastinal structures are going into the lung, and from the lung structures are getting into the mediastinum. Mainly these are pulmonary vessels, artery and vein. There is also few lymphatics and bronchi. As you know, the bronchi are air containing, so will not cast a shadow. Lymphatics are the least contributing thing to the opacity of the hilum. So in the hilum assessment, there are 3 points to remember. I'll assess the position of the hilum. I'm going to assess the density and the size. The most important thing is the position. What about the position? In anatomy, we know that the right pulmonary artery goes anterior to the right bronchus, and the left pulmonary artery goes above the left main bronchus, so that the left hilum is always at higher level. It can never be like right higher. Right higher is always pathological. Remember that. Always left has to be higher. In very low percentage patients, they can be of same position, but never the right is higher. Remember, the left pulmonary artery takes off superior to the left bronchus, so that the left hilum is at higher. The density, since both are made by these pulmonary arteries, they are of similar density and same size. Any added density should be cautiously looked for any hilar adenopathy or any vascular pathology. Now I'm going to trace the cardiac, the mediastinal margins. The mediastinum is basically the most important structure is heart. It is right sitting in center of the mediastinum, and I know that 2/3 of it is on the left side and 1/3 is on the right side. The margin that form the structure or the anatomy that is forming the right mediastinal border is the right atrium, because the right ventricle is anteriorly located. So it is behind the sternum. It doesn't form the margin on the PA view or AP view. This is a right atrium, and then you have the superior vena cava. Okay. On the left side, it is a left ventricle that is going to form the margin, superiorly part of the left atrium, then pulmonary artery, finally the aortic node or aortic knuckle. So these are the margins of the mediastinum that we are going to see. Next, I trace the hemidiaphragm. I should be able to see the hemidiaphragm in its entirety. These are the areas of cardiophrenic and costophrenic triangle. Felsen describes the costophrenic triangle as sharp as a knife. So any obliteration should be viewed as a pathology, like it could be pleural effusion, pleural thickening. Depending upon the clinical situation, you're going to proceed further. So you should see the CP angles, the costophrenic and the cardiophrenic angle very clear. Okay. The left hemidiaphragm is at lower level than the right because the heart is sitting on the left hemidiaphragm. It could be at same level and very less percentage, less than 1, as an anatomical aberration. The left could be at higher level. But you remember that because the left is sitting on the heart is sitting on the left hemidiaphragm is at lower level. Now I'll start reading the bones. As I said, the clavicle, the scapulae, the ribs. These are most important structures. The clavicle, I can see it in entirety. The scapulae, though in oblique, I could see. The proximal part of the humerus is seen on either side, and I can see the spine. Now, I move on to the soft tissue. What about soft tissue? I can see the soft tissue in the supraclavicular fossa, the neck, in the arm, the chest wall, and importantly, the breast. So sometimes you always look for the breast shadow. In females, you look for the breast shadow. Any pathology, say mastectomy, any lesion can have alteration in the normal appearance of a chest radiograph. And finally, what is obvious is I'm going to see. What is obvious is the lung, right? The lung is the obvious one. So if I start interpreting the lung, I will anyway miss to see the airway, the humerus, etc. So I see the lungs at the last. So I'm going to see the lung. I'm going to see all the areas and the upper, mid, and lower zone. And finally, something is hidden underneath the dome of hemidiaphragm. That's a part of the basal segment of lower lobes on either side. So I'll see what is underneath and what is behind the heart, etc. So again, as I said, if you want to interpret or finally diagnose a radiograph, you need two projections to localize the lesion, to compartmentalize it. So this is how a lateral radiograph look like. This is a sternum, obviously, anterior aspect, and this is spine. As we go, you can see that the heart is here. You can see the hemidiaphragm. You can see the retrosternal clear air. This is the aorta, aortic knuckle, and descending aorta. Lateral radiograph, it is a difficult call. You should remember that this retrosternal clear air should be seen. Lucency should be seen immediately posterior to the sternum, above the heart, where anterior aspect of the upper lobes meet each other. And any mediastinal lesion or any node, thyroid, etc., could obliterate this clear space. And when you trace the spine towards inferior aspect, it is becoming more loosened. Nothing is overlying here. Here the scapula is overlapping, so it is more dense. Coming down, the spine becomes more clear. Clearly you can see, and you can see the posterior costophrenic angle deep. You can see this. Any pathology like a lower lobe collapse, a pleural effusion, a lung mass is going to obliterate this clear appearance of the spine, and it is called a spine sign in radiograph. So as a mnemonic for you to not to miss any part, like ABCD approach: airway, look for the trachea and airway; B, bones; then cardiac structures; the diaphragm either side, and everything else. And finally, as I said, it's typically good idea to save the lungs for the last, simply because the pathology seems to eclipse other findings. So this is again a normal radiograph. Just I have marked the normal structures. The trachea you can see. I have traced it to the carina appearing, angle appearing normal. I can see the hilum. This is the hilum. These are the vasculature that is casting a shadow on either side. The position is what is most important. Then you can have the size and the density. Then mediastinal margins by the heart, the right atrium, the left ventricle, the hemidiaphragm, all the ribs, the clavicle, the scapulae. And if you have a lung opacity, better to describe based on the zonal anatomy. It doesn't correspond to the lobar anatomy, just an anatomical description. Better for a follow-up of the same pathology. I'll draw two lines, horizontal lines, on the inferior aspect of the anterior ends of second and fourth rib, and the zones, the zone above the first line is the upper, the between it is a mid, and lower it is a lower zone, just to anatomically localize the lesion. At the end of this normal anatomy, I want to look again at certain areas called the hidden areas where the lesion could be easily missed by anyone. So these are the apex, the hilum, the retrocardiac location, and the infradiaphragmatic lung. So can you say what is happening here? I know it's not an interactive session. I'll describe. Mostly it looks normal for me, but I think the lung volume is on lower side here. The first look reveals that. And if I tell you that there is some added opacity on the retrocardiac location, can you appreciate that? I'm not seeing the lung markings as I have seen in a normal radiograph. Okay. So this is a radiograph where you can see the lower lobe vessels going right behind the heart, and it is appearing more loosened here. But in this radiograph, you could see that some added opacity, which has a straight border right up to the hemidiaphragm is seen. This is nothing but a collapse of left lower lobe. Okay, so always look the radiograph again for this pathologies in the hidden areas. So what do you think? So I have taken 3 more radiographs here. And do you think they are normal, abnormal? What are they? What are they? So as I said, on description of my radiograph anatomy, this appears abnormal, right? This has some mediastinum which is appearing very large. I can't see the hilum, right? And another one, again, there is something happening in the superior mediastinum. I can't see the knuckle. I can't see the hilum properly. And again, this is appearing normal. It's almost normal. So these are just radiographs of an infant, a 3-year and a 12-year. And what is this structure? So as I said, it's a normal. So it has to be some normal structure. What is there in the infant which we do not have? It is a thymus. It's an organ related to the immune system, which atrophies as the child grows. By the age of 2 years, we don't see, in normal setting, we don't see the thymus on the radiograph. By the age of 2 years, it starts to atrophy, and by 8 years, we won't appreciate in the radiograph. So before landing upon saying the diagnosis of a mediastinal widening or a mass in an infant radiograph, in a pediatric radiograph, be very cautious that thymus is a structure which is there, normally there, which could mimic a mediastinal widening. Okay, and you should remember that we could never get a normally positioned radiograph in a pediatric clinical scenario. You know how difficult is for them to position adequately. So remember this point. And I cannot stop this normal anatomy without saying a few things about the tubes and lines. When you have a radiograph taken in an ICU setting, invariably there will be tubes and lines. So it is important that other than for diagnosing pathologies, you should know the normal positions of these tubes, right? I'll just briefly mention a few ones which are important. Okay. First is an endotracheal tube. First, endotracheal tube, the end. As we know, it's put in the trachea for ventilation, right? The tip should be around 3 to 5 centimeters above the carina. The tip should be positioned 3.5 to 5 centimeter above the carina. This is the endotracheal tube. You can't see the trachea, but you see a parallel tube in the trachea. This is the endotracheal tube. Okay, the tip should be above the carina, 3.5 to 5 centimeter. Why 3.5 to 5 centimeter? Because in expiration, if it is too low, it can go into one of the bronchus, mostly the right bronchus, and preferentially the right will be ventilated and left will go on to collapse. So you should know, clinicians send for radiograph from the ICU to look for, to verify whether they are in the normal position. And the wires that are going outside with the metallic clip is a ECG lead, okay? And you can see a small millimeter size tube that is going to the paralleling the right mediastinal margin, right up to the SVC is a central line, central venous catheter. And the third one is a nasogastric tube. You can see the tube going down across the chest wall into the abdomen, and usually the tip is 10 centimeter below the G junction and go deviate right to the stomach. And the position should be ascertained, because sometimes in comatose patient, in patient who was non-responsive, the tubes can get malaligned, and the radiograph, the normal tip location, the normal anatomical location should be known by the clinician. And here you can see the chest tube put for a pneumothorax. Okay. Now we have assessed clinically. We know how the normal structures appear, but before embarking onto a diagnosis in a radiograph, always remember that you are going to answer a clinical question. You have to take the clinical history, examine the patient, and that is the way you can have a sensible diagnosis. Always answer a clinical question, because a pulmonary edema, an ARDS, a COVID pneumonia, a patient can have a similar radiographic appearance. Okay, an infective pneumonia, a cardiac failure, a viral pneumonia can have a similar appearance. So you should know the clinical background for which the patient is taken for a radiograph. So you are going to answer a clinical question. So the pathologies, as I said, either the pathologies could be white or it could be a dark. We'll see one by one. Okay. So this is a patient, an elderly male who had a chest pain, dyspnea, had fever. The clinician examines and there was no breath sounds on the right side. As we have seen, there is a whiteout thorax. I can't see the aerated lung on the right side. I can see the hemidiaphragm. And the diagnosis is left pleural effusion. You could see the mass effect onto the mediastinal structures. The trachea is grossly deviated to the left side, the mediastinum to the left side, and this is a pleural effusion. The trachea can be seen deviating away from the opacity. Differential diagnoses are pleural effusion, empyema, consolidation, or mass. So step by step, you are going to approach the radiograph. Is the pathology white or black? It is white. So is it causing mediastinal shift or not? If it is there, it could be a fluid, it could be a pulmonary edema, it could be a pulmonary hemorrhage, it could be a mass. By seeing the opacity, the morphology of the opacity, like if it is a fluffy, a cotton candy, a cloud-like appearance, the opacity we are describing is of alveolar origin. Okay, keep in mind that. If it has a very well-defined margin or have a spiculated margin, we are describing about a mass. If there is a volume loss, then in an elderly male, it is a manifestation, not a cause. So we'll come to it later. Whenever you have a volume loss, there is a whiteout area, but there is the mediastinal shift is to the ipsilateral side, then it is a collapse or atelectasis that you are dealing with. But it is and atelectasis itself is not a diagnosis, it's a manifestation. In an elderly male smoker, you should raise a suspicion of a mass there as a cause of obstructing lesion. Okay, so I'm going to review in a pattern when I get a radiograph. I'm going to take a view box and I'm going to take the detailed history, the page name, the age of the patient, etc. All the old films that are available to me, I'm going to see. I'm going to ensure that the radiograph is properly taken. I'm going to assess the quality. And now I'm going to seeing the lung, whether it is a black area that is abnormal or whether the white area that is abnormal. I'm looking at the hilum for any enlargement. I'm going to see the cardiomegaly, present or not, whether structural deviation is there, associated bone, soft tissue abnormality. And if the patient is from ICU and there are lots of tubes and lines, I'm going to see the position is normal or not. So the detailed checklist, the quality, yes, the name and name of the patient, again, the details. One thing I want to emphasize at this point is correct identification of the patient should be established, because then it can have medico-legal ramifications. And one more thing, while viewing a radiograph, I'm going to see the marker on the radiograph rather than the cardiac apex, meaning I'll see the marker as L and put the radiograph likewise. Otherwise, I'm going to be in trouble in a case of situs inversus. Okay. Again, the same thing, the same we have evaluated after seeing a pathology. Not only the pathology I'm going to see, but I'm going to evaluate in detail the rest of the structures that I usually see in a radiograph. The 𝗖𝗓, the position, the clarity, the size, the cardiophrenic angles, etc. So these are the radiographs of different patients with the same diagnosis of pleural effusion. It could be minimal, it could be a moderate or a massive effusion, as in our case, where initially there will not be any mediastinal sheath. There could only be a crescent obliterating the angles, cardiophrenic and cardiothoracic angles. As the effusion increases, more and more volume of the hemithorax is occupied by the fluid, the mediastinum is going to shift, and the patient is going to be more and more symptomatic. And before going in another thing, at this point, I want you to remember about lateral decubitus. Before going to put in a needle, you want to see that whether it is a loculated or a free effusion. Just ask for a lateral decubitus view where the free fluid will gravitate towards the dependent area and spread towards the dependent area. Okay. So this is another patient. Say he's a hypothyroid and presented with dyspnea. What I'm able to see is I can see the ECG leads. Other than that, there is cardiomegaly. That's what I'm seeing, cardiomegaly. And in a case of myxedema, a chronic dyspnea may be due to a pericardial effusion. Okay. So what is this? Again, it's a radiograph. I'm seeing something is happening to the lower zone. I think the volume of the right lung is smaller than the left side. And I could see an added opacity which is obliterating the heart and the hemidiaphragm. So this is as I said, something which is white and is causing volume loss, is likely representing a atelectasis. So atelectasis, as I said, is not a disease itself, but should be regarded as a manifestation of an underlying disease. Like in a middle-aged smoker, a lung mass should be called for. As in here, you can see, if you look carefully, I can see a rounded mass obliterating the bronchus intermedius right here. If you could appreciate, can you see this? There is something that is, I can trace the airway, the right main bronchus, and something is there obliterating the bronchus intermedius, and this is the collapsed lower lobe. So in a smoker, it's likely a mass that is obstructing. In a patient who is asthmatic, recurrent mucus plugging into the bronchus can cause collapse of the lung. In young children, there could be inhaled foreign body. Okay. So another patient with fever, lower chest pain. What are you seeing? I mean, something is happening in here, right? There is some added opacities here. It's not very well defined. The one thing I can tell you that I'm not able to see the right heart border very clearly, but I can make out the hemidiaphragm clearly here. I can see the lower basal segments of the lower lobe underneath the diaphragm, but I'm not able to make out the right margin of the heart. and there is an 𝗕𝗏𝗏𝗏𝑜pacity. And I have a additional view which is overlying the cardiac margin, right? The opacity of the heart is increased here. So this is a case of consolidation, and it is due to fluid, pus, a mucus, even cell that is filling the alveolus. It is an alveolar pathology. Pneumonia is an infective condition. Consolidation is the basic pathology. Pneumonia is the clinical condition. So at this point, I want to describe a sign to you. If a lesion is obscuring the normal margin or the normal 𝙎𝙖𝙖𝙖𝙤, that is called the 𝙎𝙖𝙖𝙖𝙬 sign, which is more popularized by Ben Felsen, is seen here. As I said, there is some opacity whereby I cannot see the right heart margin. This is the 𝙎𝙖𝙖𝙬 sign due to this lesion in the middle lobe of the right lung. How do I know that is middle lobe? Because the anatomical lobe that is contiguous or in contact with the right margin of the heart is the right middle lobe. So any pathology in the middle lobe which is closely abutting the right heart margin will cause loss of that margin. So basically the loss of 𝙎𝙖𝙖𝙬 or loss of the outline is the 𝙎𝙖𝙖𝙬 sign. Okay. So here, what is 𝙎𝙖𝙬𝙬? Can you see something is happening behind the heart? Can you see that? I'm not able to see the lung, normal lung, but opacity behind the heart. But it is not obliterating or altering the left heart margin, but it is obliterating the medial aspect of the hemidiaphragm. Can you make out this? So this is a lower lobe pathology rather than a lingular pathology. On the right side, the heart is abutting the middle lobe. On the left side, the lingula, inferior lingula segments are abutting the left heart margin. Rather, the pathology is 𝙎𝙖𝙖𝙬𝙬 the or obliterating the medial aspect of the hemidiaphragm, meaning it is the pathology of the basal segment of lower lobe. So to localize the pathology to a particular segment, the sign is used. Okay, it's a loss of normal 𝙎𝙖𝙖𝙬 is described as 𝙎𝙖𝙬𝙬 sign. Okay, so this is 𝙎𝙖𝙬𝙬 sign. Another sign, you can see bilateral white lung, whitened opacities in the lung with branching lucent areas, branching black areas into the lung. Meaning, here I can see the trachea, the carina, the bronchus, and I can further trace the segmental bronchi into the lung, which I was not able to do so because all of these terminal bronchioles were surrounded by the aerated alveolar sacs and ducts, right? But here something occupied here. So I have started seeing the air in the bronchus, and that is called as air bronchogram sign. Okay, this doesn't mean that it is a benign pathology. It only means it is an alveolar pathology. The alveola is filled with either a fluid, a mucus, cell, blood, or anything. Okay, what does it cell mean? Because in adenocarcinoma, bronchoalveolar type of adenocarcinoma can exactly look like a bronchopneumonia. Okay, in that the cells are filling the alveoli. Okay, so these are different patterns of consolidation. As I said, consolidation is an alveolar pathology. The whiteout part is a pathology, and the margins are fluffy, ill-defined, cloud-like, cotton candy-like thing. So this is another clinical scenario. It's a very interesting case. It's a female patient who presented with acute dyspnea, tachypnea. She was tachypnic, and on ECG there was a massive myocardial infarction. She was hypoxemic. So what is the diagnosis? I can see cardiomegaly here. I can see white opacities towards the mid and lower zone. I'm not able to see the CP angles. So here there is cardiomegaly, alveolar opacities, pleural effusion. And this is a case of pulmonary edema. Okay, a companion case. Another patient who had treated with urinary infection, urinary sepsis, and during the hospital stay, patient suddenly went for a respiratory failure, intubated, and this was a radiograph. You can see pulmonary opacities on either side. There is no cardiomegaly. I can see the CP angles clear. The CP angles are not obliterated. And this is a case of acute respiratory distress syndrome. So the clinical presentation of pulmonary edema and ARDS are similar, but here it is a syndrome of acute respiratory failure secondary to a medical or a surgical emergency. For this acute alveolar damage, either due to toxic damage to the alveoli due to a pulmonary cause or a non-pulmonary cause like sepsis, acute pancreatitis, a drug overdosage, etc. And this is ARDS, the prognostically bad one. This is a case setting of polytrauma. I can see that something is more loosened on this side, and I'm not able to see the ribs properly. I cannot trace the ribs to the posterior, and so there are multiple rib fractures. I can see what is called as loosened lung here, but I don't know whether I'm not able to make the lung marking. So there is rib fracture in the setting of polytrauma. This is there is some white opacity towards medially, and this is a case of pneumothorax. Okay, so these are two more pneumothorax for you. This is a tension pneumothorax. It's an emergency. It's a mediastinal shift here. Another one without mediastinal shift. You can see the lung markings stop short here, and there is a margin made out by the collapsed lung here, and there are no lung markings here, and this is a pneumothorax. Now, what is staring at you at this in this multiple radiographs? I am going to show one by one. I think the trachea is central. Yes, it is central. I can see the carina. It's normal. The cardiac margins are normal. CP angles are normal. The cardiac margins I have traced well. The chest wall, the bony cage, the brush shadow, everything is appearing normal except for something. The hilum. As I said, the hilum should be of similar size, position and density. Here I can see some added opacity, some lobulations are here. The hilum is normally made by the pulmonary vessels, right? The pulmonary artery and the vein. There are dense lobulated tissues here. What about this one? Again, there is something happening in the hilum on either side. Another thing, I can see some lobulated opacity in the left hilum and another on the right paratracheal region. So here I am dealing with some hilar enlargement, and here it is nodal hilar enlargement. We are either dealing with a benign granulomatous etiology like tuberculosis or sarcoidosis, or in an elderly male we should go and evaluate for a primary like muscle carcinoma, an adenocarcinoma in the lung. Okay, so it's a hilar enlargement nodal. Okay. So what about this one? I'm seeing a relatively well-defined opacity. The margins are clear. Another nodule here. In this again, the multiple nodules in the lung. These are the nodules. I'm describing it because I can see the margins here, and I can see the mass in the right hilum. So this is a primary lung mass here we are dealing with. This is a patient. If I tell you the history, it's straightforward. This is a patient who had a history of malignant melanoma, now presenting with chest discomfort. Now you know that without seeing the radiograph, it's taken for a metastatic workup, and you can see multiple nodular lesions throughout the lung field, and this is a case of metastasis. This is a child presenting with a right-sided chest pain, fever, lab parameters favoring an infection, but the lesion is looking like a well-defined mass. So one thing you should remember is a round pneumonia in a child can mimic a mass. So before calling out as a mass in a patient, take the clinical history properly. And as a rule of thumb, you take a follow-up radiograph after 6 weeks. 4 to 6 weeks is what Harrison says. You take a radiograph after 6 weeks to look for the resolution. If it doesn't resolve, then only you evaluate for a underlying any lung pathology. So what is happening here? I think the mediastinum is wide and is lumpy bumpy, right? Another one. On here the mediastinum on either side it is lumpy bumpy and widened. Here it is on the left side. Another one, if you could see, I can't see the left heart margin properly, and something is added onto the mediastinum, right? These are mediastinal masses. I'm not going to the details of masses in detail. Okay, this was a lymphoma. This was another neurogenic tumor, teratoma, etc. So this is an important clinical scenario. A child who ingested a coin, and this is a radiograph. How do you know whether coin is in the trachea or in the esophagus? That is a question, right? So when you know that the lumen of the esophagus is collapsed anteroposteriorly, so any object, I mean anything that is ingested will be oriented in the coronal plane. So in the PA radiograph or AP radiograph, you will see it in end phase, and on lateral it will be in profile. So this is in esophagus. In trachea, it is usually lodged in the sagittal plane. Okay. The cricopharyngeus is one of the normal narrow zone anatomically where it is lodged, or could be at the level of left bronchus or GE junction. Once it is passed through the GE junction, it's likely to pass off naturally. It's a foreign body. Okay, so I have disclosed a diagnosis. So this is a radiograph. So I have, in the beginning, I was telling you that while interpreting a radiograph, I should be positioning, I am going to put the radiograph in the view box, and I'm going to interpret the radiograph. Before that, we should always look at the marker that is placed. We usually place the marker on the left side or the right side. Either way, left side or left side. So you position the radiograph such that the left come to the left side. Okay, you are going to see the radiograph as though you are looking at the patient. So this is a left side. It is a left side, but you can see when you see the radiograph properly, I'm going to interpreting. I can see the trachea central, but I'm not able to see the heart on this side. The cardiac silhouette is on the right side. The stomach bubble is on the right side. This is a case of situs inversus. If I were to interpret this radiograph by positioning it the other way, by assuming that this is a left side, I would have totally missed the anatomical abnormality, right? So always see the marker that is placed. Okay. So what is happening here? Always you should know that chest radiography is not only taken for this cardiopulmonary abnormalities, but also here. What is happening here? What is happening here? That is, you can see the free air under the hemidiaphragm. Okay, this is due to pneumoperitoneum. Okay. Okay. So what is happening? Okay. So these are the two spotters for you. I hope you can see the abnormalities. The first one is that of an elderly female, and I'm not telling the history. And the second one is that of a second one is that of a young female. Somebody is marking onto something, I don't know. Anyways, yes, the pathology is on the left side. This is a case of CA breast, and she has undergone a mastectomy. You can see if you trace the right breast here, yes, it is not seen here. And what is happening here? There is no history of surgery. Where is the pathology here? Again, I can't see the breast shadow here. This is a congenital hypoplasia of chest wall. The female with pollen syndrome. Okay, there is congenital hypoplasia. The left breast, the right breast is not seen. So before going on to interpret a radiograph, you are going to take the clinical history. Okay. The final one. I'm not going to tell the history. This is a recent radiograph from one of our wards. So what is happening around here? There is Michelle? No. Hello, Michelle, can you hear me? So
Yes,
what is happening around? Yes, what is happening around in our? What is happening? This is a radiograph of a patient with COVID. Okay, so you can see fluffy opacities on either side. It's a COVID pneumonia. So always, clinical history is important to start and to end with clinical history. Otherwise, there is no point in interpreting a radiograph without a clinical history. Always start with the clinical history and answer the clinical question they are asking for. Okay, so basically, when you get a radiograph, assess the quality. You assess the whether it is not rotated properly, inspiration is done, and exposure is adequately made. You identify the normal structure, whether then look for the opacity, describe the opacity. Then, as I said, sometimes only atelectasis is seen, and you cannot have a final diagnosis made in a chest radiography. You ask for a further investigation, like a cross-sectional imaging, as in CT, to delineate the cause. Because, as I said, atelectasis is not a pathology as such; it's a manifestation of another one. So, but you should be aware that chest radiograph is the basic investigation and the most sought investigation in radiology. So, interpreting is very important, especially in the ICU setting. You should be aware that the tubes are normal. Is the nasogastric tube accidentally going to the right bronchus, and are we going to feed the lung rather than the stomach? Is the endotracheal tube accidentally going to the right lung and there is passive collapse on the left? Is the central venous catheter that is normally positioned, and is the cardiac pacemaker leads normally positioned, etc., etc., etc. So at the end of the day, it's your call. Be aware of what is happening. Be thorough with the normal anatomy and confidently diagnose. And if at all in any doubt, there are further investigation to help you out. And in a case of infective etiology, mimicking a mass, there is always a liberty to have a follow-up radiograph after 6 weeks. 6 weeks rule you should remember. And if the radiograph significantly reduced, then you are likely leading with something which is reversible. Okay. So it's a COVID pneumonia. I have a disclaimer. I have taken multiple images and data from internet sources. Intention is to use only for educational purpose. Thank you for your keen attention. Thank you.
Thank you, ma'am.
Hopefully, I have dealt with all
Thank
the...
you so much, ma'am. Can't thank you for a wonderful session. Like, it was really helpful. You came to the base level. You made sure our cement was strong over there. You really helped us in making a great foundation about radiology, ma'am. Thank you so much. And also, let me come to the questions which I have received from the participants. So one has asked me that what are the conditions in which left hilum is below the right hilum? As you already mentioned.
No, normally the left hilum is never below the right hilum. It can be at the same level, but never below the left hilum. That is what Sutton says. The left hemidiaphragm can be at higher level than the right hemidiaphragm, but left hilum can never be higher than the right hilum. It is always pathological.
Yeah, like I think they were mentioning about what are the pathologies for
okay,
it.
pathology. Okay. Any pathology. Okay. Say if you have hilar lymph nodes. Okay. If you have hilar lymph nodes, then apparently the opacity in the right hilum will mimic like the right hilum is higher, right?
Yes, ma'am.
Any node in the right hilum, we interpret the right hilum as higher. Okay.
Yes,
so when you see something is happening in the hilum and the right hilum is appearing as higher than the left side, then it is pathological. Either you are dealing with some node, a mediastinal mass, anything. Then you have to further get in the clinical queue. If that doesn't help, go for a cross-sectional imaging. Thank you.
Exactly, ma'am. Thank you so much, ma'am. And like another person from Tamil Nadu has mentioned, how prevalent is the radiological error?
Actually, left to me, you ask, the more clinical experience you get, the lesser mistakes you are going to make, right?
Exactly.
Even if you know the radiology, the basic anatomy, you are only dealing with the cross-sectional anatomy. The last person that should be making an interpretation of radiograph should be the particular radiologist, right? So
yes, ma'am.
The more the experience with the radiograph, with the clinical scenarios, with the ICU setting, the better clinical outcome and lesser degree of error.
Yeah, ma'am. Absolutely. Let us hope for that.
Keep in mind that the pediatrics chest radiograph and the radiographs from the ICU setting which are obviously technically suboptimal, assessment suboptimal, are the one which are very difficult.
Right. Yes, ma'am, absolutely. Let us hope for a future that we don't have any radiological error. Thank you for the question. And one asked, how do we like the ARDS and pulmonary edema, which you mentioned? They asked, can you like differentiate it once more?
Yeah. Okay. Can I take the slide?
Yes, ma'am. Of course, of course.
Okay. I'll take the
Yes,
slide
ma'am.
and explain.
Of course.
Actually, that's a very good question. Because both of these will be presenting as the patient will be dyspneic, tachypneic, the oxygen saturation will be, the patient will be hypoxemic. But in ARDS, the oxygen saturation will be very low. Okay, that's a clinical background. And the onset of dyspnea is very acute in ARDS than a pulmonary edema. Leave it there. The radiological approach, the radiographic approach should be, there is usually no cardiomegaly. There will not be significant effusion in case of ARDS. Okay,
Okay,
there
ma'am.
will
Okay.
be extensive pulmonary opacities without significant cardiomegaly or a pleural effusion. But keep in mind that pulmonary edema is not always cardiogenic. There could be other cause of uh, pulmonary edema where
Yes, ma'am.
cardiomegaly may not be seen. But then the clinical scenario, the clinical background is more important. Where
Yes, ma'am.
they, as I said, is a patient admitted with acute pancreatitis going in for acute respiratory failure, a patient who is history of drug overdose, in sepsis, a drowning coming, the patient came to casualty after drowning, etc. These are the clinical acute surgical or medical emergencies where there will be acute respiratory failure. Okay, the oxygen saturation will be very low for ARDS. And with the diuretic, the pulmonary edema clears in 24 hours. Okay.
Yes, ma'am.
Okay.
And another question was that, like, what inspired you to become a radiologist? Someone has become very
That is the
inspired saying this.
trickiest question. Actually, I don't know. Frankly, I don't know. I have started loving radiology after having taken radiology. So
Like,
all the,
like how we started loving the session after you took
yeah,
class, ma'am.
yes. But basically, you should not be in the misconception that you need not be knowing the clinical details, nor the clinical background, nor the this electrolyte, what are the normal levels, etc. And you need not read or know all those things, and finally come to sit in an AC room and interpreting the images only. That's not the way. That is not at all the way. It is the best thing to have a clinical knowledge to become a better radiologist. I would like rather be a clinical radiologist than a mere radiologist.
Exactly, ma'am. I like how you have mentioned in your slide. First of all, the history matters the most. Yes, ma'am. Definitely. Thank you, ma'am. Thank you so much. Yeah, I'm like overwhelmed with your radiology slides, everything. And I hope in future we'll have more sessions with you discussing about the next organ system also. I hope it's fine. So thank you,
Thank
ma'am.
you all for your thank you.
Yeah, thank you so much, ma'am, for your time, for your
Right.
efforts you have put in.
Thank
Yeah,
you.
and let me also thank all the organizing team of SIMSA, Ajit, Pravin, Pranav, M. Adira, Aisha Omer, Rohit Jimrist, and all of you have put such efforts and made this thing happen to be true. Thank you so much. Thank you so much. Here is Michelle signing off.
Sorry to interfere. Thank you all the organizers from my side. Keep learning always. And we
Thank
shall
you,
talk
ma'am.
pandemic.
Thank you, and thank you so much.